Peter is a consultant at St George's in London, and he's also part-time in specialist private practice. He last spoke to this group nearly 15 years ago, also in English, I think. He's a farmer's son, and a very pragmatic and practical approach, and I can't think of anyone better to give us whether we should go for implants or endodontics. I'm sure he won't be shy in telling us his views. Thank you, Peter.
Thank you. Right. Good morning. Timing-wise, I mean, when we want to stop, just tell me we'll stop. Okay. Well, okay. I'm hungry too, though. Right. Thank you for the invitation. I know Ken's gone, very, very good, but thank him very much for inviting me. I'd like to... These are the issues we're going to discuss. It's going to be a cine show, okay? So that's how it's going to go. I'm going to start off with patient-centred outcomes. That's where we're going in terms of research, evidence, funding, etc. What do patients think of our treatments? Not what we think, what do patients think? And if you fit an implant-supported restoration in a patient, we may think, great, the occlusion's fine, this, but what do patients think? And I've been asked here to talk about the difference between an implant-supported restoration versus a tooth that is restored that's been root treated. And if you look at the evidence is quite clear. Okay, OHIPs. Now, the OHIP score is the score of negativity. So the lower the score, the better the patient likes it. It confused me for 2 years before I understood that, and I've just passed that on to all of you. And the OHIP scores are very similar for fixed teeth, whether they're supported by a piece of titanium or whether they're supported by a dentine root. Very straightforward. So in your hands, the patient will be as happy or unhappy, depending on the patient, in relationship to restoration, whether it's an implant or whether it is a tooth that is restoring the restoration and supporting the restorations. The other things, in terms of implants versus teeth, there's one other area I think is important, overdentures. We've just been hearing things about overdentures. We do not need to be helping ourselves to natural teeth if we can, because if we look at the difference between an implant-supported overdenture versus a natural tooth-retained overdenture, the OHIP scores are about the same. So again, with the overdenture situations, if you've got natural teeth, I applaud what's just been said, you want to try and keep them. Now, if we're talking about fixed implants, is a balance, and particularly at the front of the mouth, it's a balance, because you're putting titanium in where bone is and where teeth used to be, so you're not putting it in the same situation. And we all know that lip line's important, and the great news for lip line is as we get older, we show more of a lower teeth. It's a part of the male ageing process. We all go south, and males particularly start showing a lot more of their teeth in middle to older age, so that's great news. It means that we haven't got the high aesthetic issues. Women, unfortunately, show much more of their front teeth, and men are much more likely to have disguise of the central incisor teeth. Now, this is a lady, a very nice lady, who has a terrible muscular problem, and she fell at home, and she lost her front teeth. And she had a nicely made denture, which basically, one night when she was asleep, dislodged from her mouth and nearly killed her because they couldn't get it out of her trachea. And she ended up at St George's and everything, all and we set off funding for this patient in terms of this. We thought this was an exceptional clinical problem. She was a nightmare to treat, lovely lady, and very disabled. And I just want to show you this lady, because this lady basically had a denture that looked a lot better than these implants. We have the sound? Sound? Sound and honour? Any sound?
Things good?
Well, yes, thank you.
Good.
Yes,
Better
yes.
than the dentures, are they?
Oh, God. There's no comparison.
Now, remember that. This lady is a lady that was a tough character. She's got a tough disability. She's strong physically, and she's strong mentally. For her, the change from a denture to a tooth, a denture to an implant-supported restoration for her was very, very, very important. It was a life-saving change for her, potentially. But aesthetically, you saw her there. She had the classic, high lip line of nightmare. But if you look at the literature on how much difference there needs to be between the gingival heights of teeth in comparison to the neighbouring teeth, for patients to see a difference, you're up to 2.5 millimetres. So it's really what you were saying yesterday. How good do these things have to be aesthetically, and how perfect? And I think the answer is probably not that much, to be honest. I think we can get away with a lot. Right, dentist decision-making affected by experience and formal training. Is it an issue? Let's go to Hong Kong. 2014, they looked at 3 types of dentists. They looked at GPs putting implants in with no formal implant training, GPs that were under training in Hong Kong, and GPs that had done a formal training program in Hong Kong. And they gave them 9 scenarios of different scenarios of teeth, restorability, training, etc., and asked them what they would do. There was differences, big differences. Conclusion, in Hong Kong, I've never worked in Hong Kong, I don't know how the health system works there, but in Hong Kong, dentists who were under training or trained in implantology opted not to rehabilitate as often compared to Hong Kong GPs that had no formal training. 3 times as likely that the GPs with training or under training to retain compromised maxillary molars, particularly, with or without pain in comparison to GPs without any formal training. GPs who place implants in practice without formal training prescribed many more implants. Less other options were explained to the or suggested to the patients to restore a space than GPs that have under training or have had formal implant training. And GDPs were less likely to root treat teeth and were more likely to suggest treatment options where outcome were not necessarily robustly supported by evidence. So the training in terms of implant training will play a part in decision-making in terms of whether you choose to retreat a tooth, preserve it, or whether you're choosing to remove a tooth. We can go to North America, conflicting evidence there. In Canada, there seems to be an increasing preference now for according to this study, for implant-supported restorations when GPs were asked and surveyed. In America, interestingly, there doesn't seem to be a massive shift in terms of the study quoted here, although there is a perception by dental practitioners in America that implant treatment will be more successful than endodontic revision or endodontic treatment. American insurance companies, you'll know the Peterson and Lang papers. This is a core paper in terms of third parties, insurance parties paying for dental treatments in America. And their gold rule seemed to me that a restoration needs to have a survival of at least 90% at 5 years, ideally around 95%. And at 10 years, it needs to be between 85 and 90%. And you'll see that fixed restorations on natural teeth and restorations supported by implants tick those boxes. You'll see why resin-bonded bridges don't, and why resin-bonded bridges in North America are not, they're perceived to be temporary dentistry. Because the figures they use when you start putting all of the studies together, your survival rate drops of a resin-bonded bridge down to about 65% at 10 years compared to all of the others that are well in that 85 to 90% percentile success. Now, if we start comparing what happens to teeth that are root treated with teeth that have been restored with an implant, and there are a few of those studies, the evidence is the success rate is about the same, or the failure rate, depending on what you're calling it, okay? About 6.1% of both teeth in subjects of these groups failed in these studies. What did they use as their outcome measure? Success, survival, survival with intervention, and failure. And I think survival with intervention is very important as we start moving through this presentation. It's not just how it survives, it's what is necessary to put in place for it to survive and how often the patient comes to see us. Now, if we look at the famous cohort groups of the studies at the Eastman Dental Hospital, which I'll be talking about, the Paul Ng and Kishore Gulawala's work, they started off doing analysis of the literature. They started with a figure of survival of teeth that had been root treated or re-root treated, that 8 to 10 years surviving about 87%. So again, you're into the Peterson and Lang success criteria. And then they looked at their own cohort group, the prospective patients. And they had survival figures, admittedly were under 5 years, it's about 4.5 years from memory, survival figures of 95.4% of teeth were still surviving after primary, i.e. de novo treatment, and 95.3% that had been re-root treated, secondary endodontic therapy. So we're well into the Peterson and Lang survival criteria. Now, this paper got a lot of ridicule in the UK. This was a paper that looked at the outcome, survival outcome of teeth that had been root treated in Salford. Anyone from Salford here? Good. 12 practitioners, they root treated lower first molar teeth to the best of their ability, and then they restored them. And they basically looked at outcome. And the outcome, survival, okay, this is NHS-treated patients, was 90% at 5 years. And the commonest and the biggest outcome indicator in terms of survival was actually the restoration, whether the tooth had been crowned or not. And if you're an endodontist, the depressing thing was there's no correlation between survival and the radiographic result and outcome. And you can see the endodontists, particularly the British Endodontic Society, wrote some horrible letters about the tickle paper into the British Dental Journal, and you can understand why they're a little anxious. Right, now if we start looking at implant fixture and superstructure survival, which I think we have to do, okay, we don't just need to look at survival of implants in bone, we need to look at what happens to the restorations we're putting on. The superstructure, those of you that work in both sectors, you know, it's a huge cost if there's a problem with the superstructure at 5 years. One of which the patient needs to be aware of. Those that we're taking on the hospitals, NHS funded case, what are we going to do with all these cases that come back with superstructure problems? Because if we start looking at what happens to implants in the longer term, they do very well for 5 years. Great. You're well up in the paper we were talking about earlier, well up into the 95 to 100% success rate in the first 5 years. But then look what happens to the superstructures as the years go by. You start dropping significantly. So you go from 95.4% to 80.1% at 10 years. So clearly there are issues, prosthodontic issues that we're going to be struggling with. Now, quickly, endodontics. In a flash, we're going to go through endodontic revision. What makes sense, what's risky, what's not risky. It's very easy. The poorer the quality of the root filling you're dealing with, the easier and more predictable it is to treat. It's straightforward. Even a farmer's son can get around this, okay? You can expect an 80% probability of getting healing if you can achieve your outcomes. If you can get your root filling down the end, if you can get the old one out, and you can basically put a root filling in, you'll get very good outcome. So you want to revise, you'll spend your time revising poorly root-treated teeth. And the great thing in the UK is most root fillings are suboptimal and they're short. It's money for old rope, but don't tell anyone else, okay? What you don't want to do, the risky ones, are where you've got, I call it iatrogenic violation of the root canal anatomy, where somebody has been in and caused a problem, a fracas down in the root canal anatomy. Perforations, ledges, resorptive defects, blockages, all those type of things. Perforation of the furcational floor, coming out through the side, this, that, and the other, or you can't find root canals that clearly have got infection with them. They are the high-risk cases, and they're the cases you're not going to get anywhere near 80% success from. A little bit about re-root treatment. Re-root treatment is now a common bit of dentistry. It should be taught at undergraduate dental students, in my view. And there's a couple of things. One of the things I learned early on, when you're doing an endodontic revision, you've got to get to the apex of the tooth very early. It has a huge effect on outcome. Don't fiddle about. You know, the GP's not going to bite you. You get in there and you get a file down to the working length. And with apex locators, etc., that we have now, we could do that very, very early because it makes a difference. To get to your working length and get patency at appointment one makes a difference. Now, if you look at Paula and Kish's work, they did a systematic review and looked at the factors that made a difference endodontically in 2008, and they were 4. There's only 4, you know. Some of them are in our gift and some of them aren't. Existing apical area, not in our gift, that's the patient. Good coronal seals in our gift, and there's 2 associated with obturation. Voidless obturation and obturation ending within 2 millimetres from the end. That's with our gift. If you start looking at things that will affect us in terms of preoperatively, presence of lesion will have an effect. Size of the lesion has an effect. The presence of a sinus, a suppuration, has an effect. A lingual sinus and a lower molar, like this case I saw the other day, that in my view is a very poor prognostic indicator and the tooth is likely to be fractured. Presence of root perforation, deviation, etc. Now, if you're looking at your peroperative factors, what you do yourself that makes a difference, achieving patency, that's getting to past the 0 reading of the root canal, very important for retreatment, very important for treatment with areas. Canal preparation. The shorter you are, the less your outcome will be. You're effectively going to drop 12% per millimetre short you are with your filling. It's as simple as that if you've got an area of infection. Your healing rate will drop 12% per millimetre you're short. You do not want to put a long filling in a root. There's a difference between a sealer coming out the root filling and a great chunk of GP. I do not want that to be my final root filling. Okay, I'm doing this treatment. I'm nervous about that. I've got to sort that out. That's my gift. Chlorhexidine as an irrigant, I used to use it. Hippie Scrub, there's evidence for their study that it was no good. And this EDTA and dynamic pumping is a thing. This irrigation, getting the irrigation into the apical third, we can do that well now. I don't care what device you use. And if you have a patient that has what I describe as stormy root canal experience pain, discomfort, all those type of things. We have to be careful because it means that they may have a greater risk of it not working. Dynamic pumping in action. I'm a cheap farmer son. I use the Final Fit GP points. I'm quite happy. 17% EDTA solution. Wash it out, and then I dynamic pump until the grey becomes colourless. And Kish's study showed, or Paula's study, showed significant improvement from doing that. Don't forget apical surgery. Apical surgery is important and has a good outcome. There's a Cochrane review on it. The studies are, there's only one or two really good studies in relationship could be looked at in the Cochrane review, but those studies showed in good hands apical surgery has a very good outcome. There's a very good review out by Shana Elias in the update in 2014 that talks about when we should use it for strategic teeth. We should not forget apical surgery. I enjoy doing apical surgery. I think with the micro kit we have a very, very much better chance of getting the sort of 80% survival, 80% sort of healing that that has been sort of discussed with non-surgical treatment. So if I have a patient, this patient was referred to me, I did an implant from the premolar, she was referred with the tooth behind. I chose not to take that tooth out. I chose to treat that surgically and control the apical with the tooth intact. Restorability and restoration. Now, you're a group of restorative dentists. We're going to have a bit of a laugh in a moment about what's restorable and not what's restorable. But the key is you've got to have a good restoration, because if you have not got good coronal seal on your tooth, the endodontic success actually will be reduced, and the survival of the tooth will be reduced. And Paula's study, 11-fold increase odds ratio to success with a good placed coronal seal. Pretty good to me. But if you want to look at a tooth with significant statistical power, this is an American study, 2004, looked at 1.46 million teeth. It's a lot of teeth. A lot of teeth. A lot of, you know. 97% of these teeth were retained after eight years, which is fantastic. But if you look at the failures was only, what, 3%? But the failures, you're looking at the best part of 100,000 teeth, I think. I did the maths this morning when I was having breakfast. And if you look at the teeth that failed, the vast majority of them, they failed because they'd had no coronal restoration. So coronal restoration in terms of tooth restorability for root-treated teeth is absolutely essential. Now, I'm going to move on. You okay? Yeah, we're going to move on a little about talk about objectivizing tooth restoration, because tooth restorability, I think it's something that we're all going to have very different views on. Alva's in the audience, I hope. She's chirpy last night. Yep, absolutely right. Alva and Derek's paper on the tooth restorability was a great bash at having a go at trying to objectivise tooth restorability. But like everything, can we agree and try to agree on it? The answer is probably not. How would you manage? Who would restore these teeth? This is a classic classic hit your jaw on a steering wheel type thing. The teeth shatter. And you get these vertical infraction lines going up the teeth and loss of cusps. Who would restore those teeth? Who would bucket them? Who would restore this tooth? These are the sort of things that we have to make decisions on all day. So let's look at 3 examples. This is a patient that I'm treating here. Would we all agree that the first tooth was relatively straightforward to restore? This becomes a little bit more complicated in terms of what you were doing. And this is the classic one, isn't it? The composite restored tooth. Okay? Caries. Yeah? You get all, even the caries have gone around the dentinal tube. But the key thing is look at the tooth tissue that's left around the periphery. It's enamel. Okay? So I actually think even though this has got a very poor restorability index score, I think this tooth's money for old rope to restore, to be honest, because I think you can use isolation techniques and you can use the material. So often it's not the amount of tooth tissue you've got, it's what type of tooth tissue you've got as well. Very, very important. And this tooth has got a relatively decent-ish buccal cusp, nothing lingually, but has got cervical enamel lingually. So as long as you can make sure that you can get your isolation in position, in my view, it's restorable. We published this in the present dental update, something about using the bite wing radiograph. A bite wing radiograph is essential for assessing the restorability of posterior teeth, because it's always perpendicular to the tooth. A parallel radiograph, the only thing that's parallel is the tube's parallel to to basically the film hole, the film. A principal bite wing doesn't go so deep, it doesn't get confused and complicated by the anatomy, you'll get a nice parallel view. So the view I take when we're talking about restorability of teeth is, can I get an impression of this sound tooth? What is going to be necessary for me to do that? And am I going to be able to get down to sound tooth tissue and record a margin that my technician is going to be able to utilise and make a crown that hopefully fits? And the downside is, if any of you have been reading these Story and Coward papers, which I think are excellent, you know, 50% of the impressions that we present to technicians in the United Kingdom, both treated privately and NHS, are suboptimal. They're poor impressions. You know, our societies, we should be shouting about this because it's wrong. Right. 50-year-old male with a symptomatic upper left 1 post crown. Can I resolve the infection problem? What can I do? If I'm looking at a patient like that, you're looking at a whole load of things. You're looking at cosmetics. You're looking at the needs of the patient, the wishes of the patient, etc., etc. But from a dental viewpoint, I'm looking at, OK, how much coronal tooth tissue have I got above the alveolar crest? How long's the root and what's in it? And what's above the root? See? There you are. If I'm thinking about an implant, how much height have I got underneath the floor of the nose? And those are the questions we ask ourselves every day. And then I ask myself, OK, if I'm going to get that periapical disease better, what have I got to do that? And what am I going to do differently and better than has been done before? And if I haven't got any good answers to those questions, the answer is I'm not going to be able to move forward very much. And when I'm restoring a tooth like that, I want to make sure there's enough tooth tissue that's got a good root that was going to hold that restoration predictably in position. Now, assuming the root is intact, assuming that you are half good at doing endodontics, assuming there's no deep localized pockets that might suggest fracture, and the treatment's done well, you've got a 5mm bit of gutter perca left, decent post left, you are going to get good performance from teeth like that. They're going to last. They're going to perform well as long as they're looking after themselves. They'll do very, very well. And Kreuger's and Metnick's work, OK? Posts. Doesn't matter what post you use. It's how much remaining tooth tissue you've got. I think the evidence of the way I read it is the less you've got, the more you need to use a cast metal post, and the more tooth tissue you've got, if you think you need to use a post, you can get away without using a metal post. If you're making an assessment of a tooth on endodontic grounds, you know, deciding to retreat a tooth surgically, deciding to take out a tooth surgically in the presence of a post is a safe but very cowardly thing to do. It minimises losses and maximises gains. There's a dentist called P.B. Abbott in Melbourne, did a study of removing 1,200 posts. He got every one of them out. Touch wood, when I try and get posts out in my career, everyone I've tried to get out, I have managed to get out without breaking the root. He only broke 1 root, less than 0.1%. So that is an overused complication. So what you're looking at in teeth is what's wrong with the teeth. Now, these are 2 teeth I think are buggered. Okay? One of them, the upper right one, has got a perforation. I think it's probably got root resorption. The upper left one has got a root fracture, and there's also fracture of the post. So in my view, easy for me. Those teeth are not restorable, sir. They need to come out. And we can talk about that and what we do. Do we do it immediately? Do it delayed? I've got no problems with that. So in terms of these anterior teeth, where they can be very difficult to make decisions, never use the presence of a post or an endodontic problem to drive your decision-making. It's the wrong way round, okay? It should be the strategic work of the tooth. What are you asking the tooth to do? How much soundness is there to the remaining tooth and caries, remaining supragingival tooth tissue, etc., and thinking about the reward, risk to reward. So how much tooth tissue have I got above the alveolar crest? Best way to find that anterior is the very small periapical films. They'll give you a very parallel view of the teeth. Don't use the big ones. Use the small ones. Forget the post and the poor root filling. It can be sorted out. There are people that can sort that out. You can sort that out. Money, you know, you can do that. It's how much soundness you've got of the teeth and what their prognosis is. A little thing I'll pass on to you, Moshofanov, 2005. What they found is if there is a space between the end of your post and the beginning of the apical part of your root filling, you've got a greater risk of apical infection. You don't have to be a rocket scientist. It means you've got a space for the bugs to thrive and survive. So that means if we're going to do these teeth properly, we've got to cement post properly. It's the only time to use a spiral filler is when you're cementing a post. You need the cement to be down the post, the tooth. You don't need any cement on the post core. You'll only wipe it up. And then all the cement is apical, and you just you pump prime your post into position. A lot of people cement post wrong, and you get I call it the Moshofanov gap. And the Moshofanov gap means that you've got a 50% chance of getting periapical area within 5 years. And in the UK, 50% of post crowns have apical pathology. We okay? You calm? Okay, tooth restorability and strategic worth. This is a patient I placed these implants in 2003. Patient in practice. Okay, comes along, didn't follow up. The patient chose to be followed up by the general practitioner. And then in 2006, they refer me, the patient comes back with a molar, lower left 6, lower left 7, with symptoms, periapical disease, etc., etc. And the letter says, could you please place another implant in this patient? Now, I know we've all had a lot to drink, okay? But hopefully everyone can see I've got some peri-implantitis associated with one of my implants here, okay? And what does that mean to me? Well, that means to me this tooth becomes very important to preserve because we've got a patient here with a proven biological susceptibility to peri-implantitis. So this tooth, to me, is not a tooth that should be extracted. I think it's got a lot of coronal worth, and the most difficult part of the tooth is distally, and I think you've got a decent amount of sound tooth tissue above the alveolar crest. So the upper left 7 suddenly becomes a tooth that is important to root treat. It's important to restore properly. It's important also that we need to think about how we're going to restore this tooth afterwards as well. And then it's about how we get the patient to modify their behaviour. And I think what we heard this morning is periodontal care, etc., a lot of it's about motivational powers. And good hygienists and therapists and good periodontists have got to have good power communication skills, in my view, to get this message over. Biggest bottle brushes TP brushes you can get in town, in between the gaps. And if necessary, don't be afraid to modify your restoration for cleansability. And if you start following these patients up, okay, over the years, you can maintain them. It's a battle, but you can maintain them. And I think peri-implantitis is going to be similar to what this bloke used to say to me, and he was one of the 4 people that Ken was mentioning earlier, old Bernie, one of the finest clinicians I've ever come across, I'll be absolutely honest. He could do it all, but he knew what he should be doing. And Phil Ower and people like Mary, there's a lot of people in this room that have been very heavily influenced by Bernie Kieser, including me. And I think of him every time I show these patients how to clean. And bleeding on probing around implants is bad news, but 50% of implants, the evidence is that bleed on probe. That's not good news having bleeding around probing, but it's a common problem. So the more skills you have, so the more you can do in terms of foundation skills, implantology, whatever, I think some of these decision-making problems becomes very difficult. And I think the case on the left is virtually a lecture on its own, and clearly we haven't got time for that today. The case on the right is a patient who was hit with a hockey stick, and I was, again, referred to me in the practice, root-treated these teeth, and you can clearly see this patient has got irreversible resorption affecting lower right 2. What do you do for this patient? And here's the other case, isn't it? A 35-year-old, front of the mouth, that tooth had it, okay? It's either a resin-bonded bridge or an implant, and then you're into, do you do the implant immediately or do you do it delayed? And I've done a lot of immediate implants in my life, and to be honest, I quite like doing them. I'm very aware that people are saying, actually, you should probably do implants better, doing them delayed and going for the osteoblastic stage rather than putting them early and going for the osteoclastic stage. There's a study showing that you may not have much labial or as much labial bone as you think you've got in immediate cases, but I quite like doing them. And in terms of patient outcome, I think most of us in practice that do them, and patients pay money to have them done, if they didn't look very good and weren't going very well, we wouldn't be doing them. But clearly, there's risk to reward with implants. We know what that is. If you look at all of the patients with implants, the studies would suggest that 10% of implants, all implants, okay, display peri-implantitis in 20% of all patients. If you're looking at certain groups of patients, that'll be more. What are the risks of putting implants in? Well, you know what the risks are, okay? IV bisphosphonates worry me a lot. I think particularly for carcinogenesis, they worry me a lot. The big the Bron cases that I've seen in my job, it's about the IV bisphos for carcinogenesis. I think they're the ones that we should be very worried about, and clearly radiotherapy. Uncontrolled diabetes, immune disorders, you know what they are. Local factors, poor OH, chronic periodontal disease, parafunction, state and position of the naturing teeth. Chronic apical periodontitis, we'll talk about a little bit, is very important because you've got to eliminate it next door to implant sites, otherwise you can get retro peri-implantitis. Anatomy, soft tissue type, and I have a big bugbear about keratinized mucosa. So if you look at a peri-implantitis, this is a case of mine, again, another peri-implantitis case. 2000, I think I put these in, 2001. She was knocked over in Bromley High Street, trauma case, and grafted and 3 implants. 2002, she was an intermittent smoker. If you read the periodontal journals, they've got this lovely thing called oscillators, smoking oscillators. A lot of smokers oscillate. They have some stress, they go back to smoking. She's an oscillator. No evidence of periodontitis at the time the implants were done, but clearly she's developed peri-implantitis around the upper left implant. And I take that on the chin as a lot of that being my fault, because I have overcompensated, I think, and ridge-lapped the pink ceramic around the implant on the left-hand side to try and make this look natural. And I think it's done her biologically no good at all. So how have I managed this? How have I kept this under control? I modified my restoration. And we have to be bold enough to do that. And when we have peri-implantitis, we always blame the patient, but look very much. Donos at the Eastman calls it patient-related factors and dentist factors in terms of peri-implantitis. And I think he's got it right. And this partly was me, my dentist factor, trying to make this implant-supported bridge look good around the neck of the teeth because her implant showed it. And if you see her at 2014, so she's a long way down the track, that's a cleansable bridge. It looks okay-ish, I think, okay, with the ceramic work that's been done well by the technicians. But when I first made that bridge for her, it was not nearly as cleansable. And I think we have to get that balance right in terms of fixed prosthodontics around implants. Now, quickly, okay, patients get periodontal problems with their natural teeth, so how do implants fit in with this risk? We've heard eloquently about periodontal risk in terms of natural teeth. What happens with implants? Well, it seems that implants go best in relationship to tooth loss. Trauma, caries, hypodontia seem to be the best patients to put implants in. Makes sense, doesn't it? Yeah. Smoking. Yeah, smoking's an issue, okay? Smoking's an issue. This is us last night, all out in the razzle. Smoking with a history of periodontitis, so smoking plus perio, if you look at the survival difference, okay, there's a lot wrong with these studies, okay, as you all tell me. I know there's a lot wrong with this. There's all sorts of things, clustering of patients, but the differences are big. 80% survival, you've lost 20% of the implants of the smoking perio group over 10 years in comparison to the smokers, okay, with no history of perio, where you've got 100% survival. So I think with implants, you've got two types of smoking patients. I think you've got those smoking patients that are periodontally non-susceptible or resistant, and they're probably the best patients you could ever put implants in. And you've then got the perio patients where you've got periodontal disease susceptibility, and they're the worst patients you could put anything in. Now, if you start looking at the Ricasuto paper of 2012, okay, the numbers are small. This is patients where they decided the teeth should be taken out and put in the, the titanium implants. Numbers of implants lost in the study period, 12.3. Okay? How did the periodontally involved teeth perform in the same study group? Bigger numbers of teeth, 2,143 teeth, 129 teeth were extracted, 6%. So in the same cohort of patients, okay, natural teeth had 50% less failure. And you've got to remember, the implant was put in, bone around it presumably, failed, in and out, where your natural teeth were slowly losing periodontal attachment through that study period. Now, those of you that work in hospital units that deal with, sort of bigger problems, we do more complicated procedures. And the problem is, with doing more complicated procedures, we produce more complications, and particularly me. And the more you're relying on a graft to house and integrate an implant, so the worse your native to non-native ratio becomes, the greater the risk you have of running into trouble with implants. And if you start looking at significant hypodontia patients where you are really massively short of bone and using chunks of patient's bone to put implants in, your complications and failure rates are pretty high in those patients, and you've got to be realistic of that. The trauma patients that you're grafting, the oncology patients that you're putting in grafts, you're into bigger, much bigger failure rates, and everybody needs to be absolutely up to speed. They're not two of the same things. And if you're doing big grafts, you've got to be prepared for big resorption. It's a case that I did with a colleague recently. These are intermediate resin bonded bridges. They were flush with the soft tissue when we grafted the patient. This is 3 months later. That graft has lost 20, 30, even 35% of its three-dimensional volume. And in the lower, we've lost our keratinized tissue. That means the patient is going to struggle potentially to clean for the rest of their life. Now, It's a great job. I don't know if any of you have used the new Biotech implant fixture removal. I think it's a fantastic bit of kit, and I think anyone dealing with these groups of patients is going to need one in their units, because it's a this is a patient that's had her mandible reconstructed. There was risk that you could break her mandible, and it's been a very smooth exo implant on denture, or whatever you want to call it. And I would say that any of you doing a lot of this work, that, instead of a Trefine, in my view, wins every time. The downside is you've got to have an intact implant at the top. You can get the device down. I've got a video of using it on my website, so if you want to see it used, it's easy. Even I got the hand of it really quickly, really easy. Right, OK, my conclusions. I'm getting nearly there. It's been, you all right? From a periodontal viewpoint, the periodontal patient needs to earn their implants with the proof of long-term compliance. They need to earn it. The amount of patients that I see have lost all their teeth through periodontal disease, they've still got bleeding on probing and pocketing everywhere, and then somebody wants to put in 20 implants, patients need to earn it. They need to be in a position biologically where they're on top of their business. We must be honest and do not value the importance of even significantly periodontally involved teeth, because look at the Hirschfeld and Wasserman study, long time ago, 600 teeth, or 600 patients, wasn't it? Yeah? That holds mustard, that study. Holds mustard. Survival is very good. Smoking and periodontitis, it's a big, big risk. It's important that we know the risk we're getting into and the patient knows the risk they're getting into. And I find those type of patients often drink a little bit more than they should. Terry, I find that. Okay, they approach their control of their type 2 diabetes as though it's a joke. And they put pressure for same-day teeth. They don't want to take their own responsibility for their problems, and I think that's a worry. So I'm going to quickly go through my conclusions of what I've tried to talk about today. In terms of implants fixed dentistry, the outcome of implants is good. Let's be honest about it, but we need to know what the risk is. The issue with implants is probably the superstructure is where the potential problems are going to be. The aesthetics are more unpredictable because you're putting implants in an area where teeth used to be, and there'll have been resorption when the teeth have come out. Often we need to create bone to do that and have the base that we can put the implant safely. Recession in implant means showing of metal. If we're allowed to have 0.2 millimetres of bone loss per annum, if somebody's got an implant for 50 years, you can do your maths and see how many millimetres of implant potential is going to be showing at the necks of the teeth. They seem to be less good at resisting periodontal disease, particularly in comparison to natural teeth, in the same circumstances. The final prosthodontic option does not buy time. I think in patients we need to be thinking about buying time and recycling. We're still learning how to resolve biological complications, and you will all be seeing these cases, and you'll all be scratching your heads like me and say, what should we try and do here with this case where you've clearly got some bone loss around implants? Potential violation of anatomical structures. It happens. I had a patient last year, and I put an implant in an upper right tooth space, and the patient came back to see me the week later. We were talking about this in the bar last night, and her upper right one was completely black. I devitalised the upper right central inside tooth, and that's an anatomical violation. So now it's an unfavourable outcome. They're easier to remove now. I'm much more confident and relaxed about removing implants. I think we can do it much less destructively. I think there's been a lot of very clever tooling now in relation just to do that. Survival in decent bone with adequate length and diameter is good, but the implications from their biological loss and failure are potentially dire. A couple of cases, I would say to you, this top one here I treated the other day. I did that implant. The patient then went 3 or 4 years later to have more work done because I was too reassuring and expensive. And from Bulgaria, comes back to see you, new restoration, hybrid restoration on my implant. They haven't even got the thing to fit. And the implant's got what I describe as retro-periimplantitis. And you're into endodontic skills. You're into basically going in surgically, removing infection, debriding, using all the instrumentation you have. Endodontics really lends itself well to this part of implantology, as it does to taking screws out microscopically. Really does lend itself well to it. And I'm finding my way in these cases, and you'll all having cases, and you'll be putting lotions and potions in. I rang up Mike Norton and says, what would you do for this? And I did roughly what he said. This case in the lower, root canal treatment. If you've got an apical area, you don't have to take the tooth out. You can root treat the tooth in the neighbouring tooth. The issue is, how long do you have to wait following the root canal treatment before you put your implant in, with that risk of you potentially getting bugs and bacteria entering in terms of the end of the implant. And as a rule of thumb, I would root fill the tooth and I'd review the patient at 3 months and take an intraoral periapical radiograph. And there's evidence of non-surgical healing, evidence of it, okay, not completion of it, I would put an implant in. Patients, perio patients. This is a long face patient, okay? This is not a perio patient. This is a long face patient where we're effectively taking the alveolar process off and moving everything up. She's a very, very sort of odd-looking patient. There are a lot of people that would do this for people with periodontal disease because they're worried about where the potential line of the implants are going to be in relationship to periodontal. I think that is madness. I think it's absolute madness. You've got no plan B and it's damaging. Natural teeth, aesthetics is more predictable because you've got a root. You're using what was there. You've got bone. You've got soft tissues, hopefully, to play with. Survival and integration, I think when you're comparing survival with implants versus natural teeth, they're the muchness, okay? Periodontal disease can be predictably controlled. We've heard that beautifully this morning. Recession, you'll be showing denting. You're not going to be showing lumps of fluted grey titanium. Natural teeth seem to perform better in the periodontal patient. They seem to do much better. If they're going to get periodontal disease, they're easier for the patient and us to control than if the implant gets periodontal disease. Keeps options open, buys us time, and most of us have learnt to resolve most of the problems associated with teeth. It avoids grafting, it avoids potential anatomical violation, and what's the worst thing that can happen? Well, the tooth will be lost and it will need to be extracted. So you're a society of, influence. We've got a problem in the UK, I think, okay? I think implantology, particularly in intramural referral practices, where they have somebody that has an interest in implants or somebody who's carted in once a month to do the implants, I think we have a problem because I think it's leading to de-skilling of dentists in prosthodontic skills. Because what you're doing here, this is Meccano, okay? You've got margins 5 millimetres underneath the gum, but it's all click Meccano. You don't need retraction cord. There's no difficulties. It's easy, easy peasy to do. This type of dentistry is much more difficult to do. Underneath the gums, building up cores, preparing teeth and crown margins, recording sound tooth. We know how difficult that is to do. And if you have the choice, I think sometimes it's very, very easy for dentists to choose something that's going to be very, very straightforward. So get the implants in and I'll restore them. It's going to be easier. And we've got to make sure that we don't, because this is one of several factors that, in my view, in this country is leading to industrial levels of dental clinical de-skilling in this country. I think it's something that I feel strongly about. Right, I'd like to, nearly finishing, hold on. I'd like to say, we all know a chap close to Kennard Society who had high levels of clinical skills extending across this area, and we spoke a little bit about him last night. I filled in for him today because I know if he'd been alive it would be him speaking, not me. And I'd like to dedicate this presentation to him, and thank you very much indeed, all of you. Thanks.